Welcome back to another deep dive. Today, we are doing something a little bit different, something that's been highly requested by those of you out there navigating the, let's say, high-stakes world of surgery.
We're opening up the heavy hitter.
We are. We are cracking the spine on the 28th edition of Baily and Love's Short Practice of Surgery.
A true classic. I mean, for so many surgical trainees, it really is the Bible. It's dense, it's authoritative, and you have to know it.
Absolutely. And today we're zooming in microscope ready on Chapter 55. The title is simple enough: the thyroid gland.
But the content, not so simple.
Not at all. So before we even make the first incision here, I think we should set the stage. What's our actual mission today?
Our mission is, I think, translation and retention. Look, we're not just going to read you the chapter. That would be, frankly, pretty dry.
And you can do that yourself.
Exactly. Our goal is to be a kind of ready reckoner. We want to interpret all that dense anatomical and physiological detail and, turn it into a mental roadmap.
100%. Think of this as your audio revision tool. We want to give you the hooks, the anchors, the metaphors, so that when you sit down with the text or, walk into an exam.
Or scrub into the theater.
Yeah, scrub into the theater. The concepts just click into place. We want you to listen to this, and then when you read the chapter, you go, oh, okay, I get that now.
But we should probably do a quick disclaimer. This is an interpretation. It's designed to make the concepts stick, but it is not a replacement for the text itself.
Absolutely. Please, go back and read Chapter 55 of the 28th edition. We're your tour guides, but you still have to walk the trail yourself.
Well said.
So the subject, the thyroid. It's often called the butterfly of the neck.
And it really looks like one.
It does. It's this small organ, maybe 20 to 25 grams. But when you look at the physiology, it just packs a massive punch.
It really, really does. And it's such a high-stakes area. Anatomically, it's surrounded by what I like to call expensive real estate.
Expensive real estate. I like that.
I mean, you've got major nerves that control your voice, major vessels like the carotid, the airway itself. You make a mistake here, and the consequences are, well, they're immediate and severe.
Okay, so to navigate all of this, we're going to use a specific approach today. We've got metaphors, we've got check-in questions, where we'll ask you to pause and think.
So keep your finger near the rewind button.
Exactly. And we've got some fictional case studies to see if you can spot the diagnosis before we do.
I love that. It really turns raw information into actual usable knowledge.
All right, let's dive in. Segment 1, the journey of descent. We're starting with embryology and anatomy.
A great place to start.
Now, Baily and Love describes the thyroid's origin, but I want to visualize it. Let's picture it as a daily commute.
A very, very long commute. And this is so crucial because, the thyroid doesn't start in the neck.
Right.
If you look at an embryo, the thyroid actually begins its life as a little bud in the pharynx, specifically right at the base of the tongue.
At the foramen caecum, that little pit you can see at the back of your tongue.
That's the one. And from there, it has to travel south. It descends down the neck, past the hyoid bone to get to its final resting place over the trachea.
And like any commute, it travels along a specific track, right?
It does. That track is called the thyroglossal duct.
And this is where our first clinical anchor comes from. Because sometimes a commuter, they leave their luggage on the track.
That's a great way of putting it. The thyroid migrates down, and if parts of that tract, that road, don't disappear like they're supposed to, you get leftover luggage.
Which is a thyroglossal cyst.
Precisely. Fluid-filled remnants of that journey. Or you might see a pyramidal lobe, which is just this streak of thyroid tissue stretching up towards the chin, literally marking that path of descent on the map.
So if you see a pyramidal lobe in surgery, it's basically a historical marker.
It's an anatomical fossil, yeah.
Now, the thyroid isn't the only traveler here. It has neighbors, the parathyroids. And I have to admit, this part always used to confuse me. You've got superior and inferior parathyroids. Logic says the superior ones come from a higher structure, right?
You would think so, wouldn't you? But embryology loves a twist. It's actually the opposite.
Okay.
And this is a key exam point that trips people up all the time. The superior parathyroid glands, they develop from the fourth pharyngeal pouch, the inferior ones. They come from the third pouch, which is actually higher up in the embryo.
So the ones starting higher end up lower. How on earth does that work?
Right. It seems backwards.
Right.
But here's the visual anchor to remember why. The third pouch also gives rise to the thymus gland. Now, I want you to think of the thymus as a really heavy backpack.
A heavy backpack. Okay.
Okay, I'm with you. The inferior parathyroids, they put on this heavy backpack, the thymus, and as the thymus descends way, way down into the chest, into the mediastinum, it drags the inferior parathyroids down with it.
Ah, so it pulls them past the superior ones.
Like an express elevator going straight to the basement. It just drags them down.
That makes perfect sense.
Well,
so the superior glands just take a short trip from the fourth pouch and stay relatively high up.
exactly. But the inferior glands get dragged down by the thymus backpack, and that explains why their position is so variable. Sometimes they get dropped off early, sometimes they get pulled all the way into the chest.
So if you can't find one during surgery, you have to look along that whole path.
You follow the breadcrumbs.
Okay, let's move into the danger zone. The nerves.
Yeah.
Specifically, the recurrent laryngeal nerve, the RLN. Baily and Love is crystal clear on this. This is the most critical structure for the surgeon.
It's the king of the neck. It's the one structure you absolutely must identify and preserve. It branches off the vagus nerve, and it controls your vocal cords.
But there's a quirk, isn't there?
Well,
The left and right nerves take completely different routes.
massively different. The left RLN is the long-distance traveler.
Right.
It loops all the way down into the chest, hooks under the arch of the aorta, and then has to climb all the way back up.
Wow.
And because it has that long runway coming back up, it tends to be pretty consistent. It comes up right in the tracheo-esophageal groove. It stays in its lane.
But the right nerve is the maverick.
The right nerve is different. It loops under the subclavian artery, which is much higher up. So when it enters the neck, it comes in at a bit of an angle, more obliquely.
Okay.
And here's the real trap. In about 1 to 2% of cases, you get a non-recurrent laryngeal nerve on the right side. It doesn't loop at all. It just comes straight in from the vagus sideways.
That sounds like a complete nightmare for a surgeon.
It is a massive trap. Because if you're digging around deep in the groove looking for it and it's actually coming in laterally, you could cut it before you even realize you're close.
So to avoid that, we need landmarks. The text mentions a few critical ones. Let's unpack Bary's ligament first.
Bary's ligament is the anchor point. It's this dense bit of fascia that binds the thyroid tightly to the trachea. And the reason it matters so much is that the nerve often runs right through it or immediately behind it.
So that's the point of maximum danger.
That's it. You treat Bary's ligament like a loaded wire. You do not cut it until you know exactly where that nerve is. If you cut blindly, you are gambling with the patient's voice.
Never cut blindly.
Never. And that's why we also use Bary's triangle to find the nerve before we even get to the ligament.
Paint the picture for us. What are the borders of the triangle?
Okay, think of it like a map. The lateral border is the common carotid artery.
Okay.
The top border is the inferior thyroid artery. The recurrent laryngeal nerve itself forms the third side. So if you gently open up that space, find the artery, the nerve is usually crossing it right there. It's your targeting system.
And there's one more landmark, a bump on the gland itself, right?
The tubercle of Zuckerkandl.
I love that name, Zuckerkandl.
Sounds like something from a fairy tale, but it's a huge warning sign. It's a lateral projection of thyroid tissue. And the nerve is almost always hidden just behind this tubercle.
So if you see the tubercle, you stop.
You stop digging, the nerve is right there.
Okay, before we leave anatomy, let's just quickly touch on lymphatics. The text mentions the Delphian nodes.
Yeah, this is a great bit of medical history. These are the nodes right above the isthmus, dead in the middle. They're named after the Oracle of Delphi.
The Greek oracle, why?
Because back in the old days, if those nodes were enlarged and you could feel them, it foretold a grim future, usually thyroid cancer, but it was mysterious. Just like the oracle's prophecies, the nodes were a sign of something significant, but you didn't know exactly what. It's a poetic reminder of how the physical exam used to be our only real tool.
That is fascinating. Okay, let's pause. We're going to do our first check-in question. So if you're driving, keep your eyes on the road, but engage your brain.
Okay, think back to that commute metaphor we just discussed. Why do the inferior parathyroid glands usually sit below the superior ones, even though they start higher up in the embryo?
Give it a thought. Visualize that backpack.
The answer is the heavy backpack.
Yeah.
The inferior parathyroids arise from the third pouch along with the thymus, and the thymus drags them down further during its descent, right past the superior glands from the fourth pouch.
If you didn't get that, rewind and listen to the backpack analogy again. It'll click.
It will.
All right, moving on. Segment 2. The engine room. Physiology and goitrogenesis.
Right, so the thyroid is the body's thermostat. And like any good thermostat, it has a sensor and a heater.
The pituitary gland is the sensor, right?
Correct. The pituitary is constantly tasting the blood. It releases TSH, thyroid-stimulating hormone. You can think of TSH as the request for heat.
So when the body gets cold, or thyroid hormone levels drop, the pituitary screams more heat and pumps out TSH.
And the thyroid responds by making T3 and T4. And Baily and Love is really specific about the difference here, which is important.
Okay, so T4 versus T3.
Think of T4 as your savings account. That's the storage format. It's bound to protein. It floats around in the blood for days, but you can't spend it right away.
But T3 is the active stuff.
T3 is the cash in your pocket. It's the biologically active currency that actually goes to the cells and speeds up metabolism. T4 gets converted to T3 when you need it.
Okay, so what happens when this engine breaks? Specifically, let's talk about goitres, the swelling of the engine.
Well, the most common cause historically is a lack of fuel.
Iodine.
Iodine. If you don't have iodine, you can't make T4. It's that simple.
And Baily and Love mentions endemic goiter in these mountainous regions, the Alps, the Himalayas, even Derbyshire in the UK, the Derbyshire Neck. Why mountains?
It's all about geology and time. Iodine washes out of the soil. So in high, steep areas, rain has leached the iodine away over millennia. The food grown there is iodine poor. If you lived in the Alps in the 1800s, you almost certainly had a goiter.
And then there are goitrogens, things that actively block the engine from working.
Yeah, the cabbage factor.
The cabbage factor.
Vegetables in the brassica family, cabbage, kale, turnips. They contain compounds that stop the thyroid from taking up iodine. It's like putting tape over the fuel intake.
So my kale smoothie is bad for my thyroid.
I mean, only if you're consuming massive amounts while also being iodine deficient. But historically, for populations relying heavily on cabbage, this was a big deal. High calcium in the water also acts as a goitrogen.
Which explains Derbyshire. It's not just the altitude, it's the limestone. The water's full of calcium.
Exactly. So here's the cycle. You lacked iodine. Your T4 levels drop. The pituitary notices the room is getting cold and screams more heat by pumping out TSH.
And the thyroid tries to comply. It works harder, it grows bigger.
That's hyperplasia. It gets huge, trying to catch every last molecule of iodine it can find. But then maybe you get a little iodine, so the gland rests. Then you lose it again, and the gland grows again. This fluctuation.
It makes it lumpy.
It makes it lumpy. Some parts stay active, some burn out and fill with colloid, some bleed and calcify. And that's how you go from a smooth, diffuse goiter to a multinodular goiter over time.
Let's apply this. Fictional case study A. I want to see if everyone listening can follow this story.
Let's do it.
Okay. Picture a 14-year-old girl. She lives in the limestone region. She presents with a smooth, diffuse swelling in her neck. It's not painful. Her mom noticed it. She goes away to college for a few years, and the swelling seems to disappear. But then at 24, she gets pregnant, and the swelling comes back. What is happening here?
Okay, this is a classic physiological goiter. At 14, she hit puberty. Her metabolic demand shot up.
Right. The body needs more heat.
Exactly. And living in a limestone region, she was already fighting against goitrogens. So her thyroid grew diffusely, that's the hyperplasia, just to try and meet that demand.
And when she went off to college?
The metabolic storm of puberty calmed down. Maybe her diet improved, less local water, more variety, more iodine. So the goiter regressed. It's reversible in those early stages.
But then the pregnancy.
It's another metabolic stress test. Pregnancy dramatically increases the demand for thyroid hormone to support the fetus. So the TSH went up again, and the gland swelled again. It's a perfect illustration of the demand versus supply equation.
That brings us perfectly to segment 3, the detective work. Someone walks into your clinic with a lump. How do you figure out what it is?
You need the assessment triad. 1, clinical exam. 2, function tests, which means TSH. And 3, imaging.
And the workhorse for imaging is ultrasound.
Ultrasound is the king here.
Now, the text makes this really important distinction between a solitary swelling and a dominant swelling. I feel like this could be a semantic trap.
It's not semantics. It's actually about risk stratification. A solitary swelling means you've got one lump and the rest of the gland is completely smooth and normal.
Okay.
A dominant swelling means there's one big lump that you can feel, but if you scan the gland, you see the rest of it is lumpy and bumpy too. It's just the biggest bully in a rough neighborhood.
And why does that distinction matter so much?
Cancer risk. And this brings us to one of my favorite anchors in this chapter, the rule of 12.
I love this rule. It's so good for breaking down the malignancy risk. Walk us through it.
Okay, so visualize the number 12.
Yeah.
If you have a truly isolated solitary swelling, the risk of it being cancer is roughly 15 to 20%, so let's call it close to 12% plus a bit. That's high.
A solitary lump is definitely worrying.
Now, if you have a dominant swelling part of a multinodular goiter, the risk is about half of that, maybe 5 to 8%, it's safer to be one of many.
Lower risk if it's in a crowd.
Yeah. And if the lump is cystic, fluid-filled, the risk is lower. If it's solid, the risk is higher.
What about gender?
Thyroid nodules are way more common in women, but, and this is the key point, if you find a distinct nodule in a male, the risk of it being cancer is significantly higher.
So a solitary nodule in a man is a huge red flag.
A massive red flag. You basically assume that's cancer until you can prove it's not.
So once we see the lump on the scan, we stick a needle in it,
Yeah.
FNAC, fine needle aspiration cytology, and we get back a result, Thy1 to Thy5. But there's a massive trap here, a critical limitation that Baily and Love hammers home.
Yes. This is the follicular trap, and I want everyone to listen carefully because this saves lives. FNAC looks at cells. You suck a few cells onto a slide.
Right.
It can tell you if a cell looks like a papillary cancer cell. They have these weird characteristic features. It can tell you if it looks anaplastic. But it cannot distinguish a benign follicular adenoma from a malignant follicular carcinoma.
Why not? Don't the cancer cells just look evil?
No, that's the problem. In follicular lesions, the benign cells and the cancer cells look almost identical under the microscope. The definition of follicular carcinoma is not cellular. It's architectural.
Architectural.
You diagnose it by seeing the tumor invading its own capsule or invading the blood vessels.
And you can't see the capsule on a tiny clump of cells you sucked out with a needle.
Exactly. Think of it like a prison break. If you just look at a mugshot of the prisoner, the cell, you don't know if he's escaped. You have to look at the fence, the capsule, to see if there's a hole in it.
And you can only see the fence if you take the whole thing out.
You need the whole lump. You need to look at it under a microscope to make the call.
Which leads us perfectly to our check-in question 2.
Okay, here it is. If you get a Thy3 result on FNAC, which means follicular lesion, why must you operate? Why can't you just watch it?
Pause and think about that prison break.
The answer is because the needle cannot tell you if the capsule is breached. You have to remove the lump, usually a diagnostic hemothyroidectomy, to examine the whole capsule histologically. You operate to get the diagnosis, not just for treatment.
Brilliant. Now let's rev the engine up too high. Segment 4. The hyperactive gland. Thyrotoxicosis.
Too much heat. The body is running a marathon while sitting on the couch.
And we've got 3 main culprits to line up here.
Suspect number 1, Graves' disease. This is autoimmune. The body makes antibodies that attack the TSH receptor, but instead of destroying it, they stimulate it.
So they basically stick the gas pedal to the floor.
That's a perfect analogy. The gas pedal is stuck down, and because it's antibodies in the blood, they hit the entire gland.
Which means the whole thing swells up diffusely.
Yeah.
And you get those other autoimmune signs.
Specifically the eye signs, exophthalmos, yeah.
Okay, suspect number 2. Toxic multinodular goitre, often called plumber's disease.
This is usually a secondary problem. Remember our 14-year-old girl with the goiter?
Yes.
If she keeps that goiter for 40 years, eventually some of those nodules might decide to go rogue and start pumping out thyroid hormone on their own, independent of the pituitary. They become autonomous.
So this is more likely an older patient with a lumpy neck they've had for years and no eye signs.
Precisely. It's not the gas pedal being stuck. It's just an old broken engine that's revving uncontrollably in a few cylinders.
And suspect number 3, toxic adenoma.
Just one single hot nodule doing all the work, and it's so active it actually suppresses the rest of the gland.
Right. Okay, let's do fictional case study B. A little contrast and compare.
I like it.
Patient X is a 35-year-old woman. She's anxious, losing weight, has tremors, and her eyes look like they're bulging. Patient Y is a 65-year-old woman. She has a bumpy neck she's had for years, but suddenly she's having palpitations and an irregular heartbeat atrial fibrillation.
That is a classic comparison. Patient X is Graves' disease. Young, autoimmune, the eye signs, the gas pedal is stuck globally.
And patient Y.
That's the toxic multinodular goiter. The old bumpy engine has finally started misfiring, and that atrial fibrillation is a dead giveaway for thyrotoxicity in an older person.
So how do we treat them? We have a treatment triad, right?
We do. Drugs, radioiodine, or surgery.
Let's start with drugs. Carbimazole.
Think of carbimazole as the brakes. It stops the thyroid from making hormone. It's great for getting a patient stable for surgery or radioiodine.
But as a long-term cure.
Not so great. It has a really high failure rate. About 55% of people relapse when you stop the drug.
Okay, so then there's radioiodine.
The search and destroy missile. You swallow a pill with radioactive iodine. The thyroid cells, and only the thyroid cells, are hungry for iodine, so they eat it up.
And the radiation destroys them from the inside out.
Exactly. It's very effective. But you can't use it in pregnancy, obviously. And weirdly, you have to be careful with active eye disease in Graves because it can sometimes make the eyes worse.
And finally, surgery. The reset button.
Right. And for Graves, a total thyroidectomy is now the preferred option if you're going to operate. We used to do a subtotal where we'd leave a little bit of gland behind.
Why not do that anymore?
Because if you leave autoimmune tissue behind and the autoimmune process is still going, it just grows back. And reoperating on a scarred thyroid neck is a complete nightmare.
So just take it all out and give them thyroxine pills for life. It's cleaner.
Much, much cleaner.
All right, segment 5. The enemy within. Neoplasms. We've touched on follicular, but let's run through the whole lineup of bad guys.
Okay, let's classify them by cell type.
First up, the most common one, papillary carcinoma.
P for popular. It accounts for about 80% of all thyroid cancers.
And how does it like to spread?
It loves the lymphatics. It spreads to the lymph nodes in the lateral neck.
But here's the kind of good news, bad news paradox with it.
The good news is the prognosis is excellent. Even if it spreads to the nodes, especially in young people, they almost never die from this.
And the confusing news?
The confusing part is that occult micrometastases are incredibly common.
Explain that term, occult.
It means hidden. If you took 100 people who died of other causes and you sliced up their thyroids really carefully, you'd find tiny little papillary cancers in a huge number of them, maybe up to 30%. They were just sitting there not doing anything. It implies that many of these cancers are just indolent. They don't want to kill you, which is why we're having this huge debate about overtreatment right now.
A fascinating point. Okay, next on the list, follicular carcinoma.
F for far away. Unlike papillary, follicular spreads via the blood, hematogenously.
So it bypasses the lymph nodes.
Usually, yes. It goes straight to bone and lungs. You might find a secondary tumor in the skull before you even find the primary lump in the thyroid. And remember,
You can't diagnose it with FNAC.
you cannot diagnose it with FNAC. You need the capsule.
Then we have medullary carcinoma.
This is the odd one out. It doesn't come from the main thyroid follicular cells. It comes from the parafollicular C cells.
C cells, and they make calcium.
Calcitonin. So calcitonin is your blood marker. If calcitonin is high, you have to suspect medullary.
And this one is often genetic, isn't it?
Highly genetic. It's associated with the MN syndromes, multiple endocrine neoplasia, type 2A and 2B. If you diagnose medullary cancer, you must check the family history and check the adrenal glands for a pheochromocytoma. It's non-negotiable.
And finally, the worst of the bunch, anaplastic carcinoma.
A for anaplastic, A for appalling. This is rare, usually in the elderly. It's hard as a rock, fixed to the underlying tissues, and it grows incredibly fast. It invades the airway. The prognosis is very, very poor.
Let's try fictional case study C. A young man presents with a lateral neck lump, but no palpable thyroid mass. He feels fine, just has this lump on the side of his neck.
A lateral neck lump in a young person is thyroid cancer until proven otherwise. Full stop.
Even if the thyroid itself feels totally normal.
Absolutely. This is the classic presentation of capillary carcinoma as a lymph node metastasis. It's an occult primary. The tumor in the thyroid is so small you can't feel it, but it has already sent a scout out to that lateral lymph node.
So you biopsy the lymph node, you find thyroid cells in it, and the mystery is solved.
Exactly. Then you know you have to go looking for the primary in the thyroid.
Okay, we've diagnosed it, now we have to fix it. Segment 6, the operating theater. Baily and Love gives a real masterclass in surgical technique here.
Yeah.
Set the scene for us.
Okay. The patient is in the rose position, neck extended, head back, usually with a sandbag between the shoulder blades. But also, the whole table is tilted feet down. That's reverse Trendelenburg.
Why feet down?
Gravity. It helps drain venous blood away from the neck, which reduces engorgement and bleeding. A bloodless field is a safe field.
The surgeon makes the incision. What are the key rules of the game?
Number 1, stay in the plane. There is a beautiful, loose fascial plane around the gland. If you're in the right plane, you can almost just wipe the tissues away. If you're struggling and cutting, you're in the wrong spot.
Okay.
Number 2, identify the oral end. We've talked about this. Don't cut anything substantial until you see the white glimmer of that nerve.
Okay.
And number 3, preserve the parathyroids. They're tiny yellow-brown. They look like little lentils. You have to keep their blood supply intact.
Now, let's talk about the nightmare scenario, the post-op hemorrhage.
This is the thing that every single thyroid surgeon fears. It is what keeps us awake at night.
Describe the scenario for us.
It's 4 hours after the operation. The patient was fine in recovery. Suddenly the nurse calls you, panicked. The patient has a swelling neck, it's tense. And they have stridor, that high-pitched, awful noise when they try to breathe.
And they're anxious?
They're terrified, they're suffocating.
So what's happening mechanically?
An artery has popped open, blood is filling the space where the thyroid used to be, but the blood has nowhere to go. It's trapped under the strap muscles and the skin. The pressure builds and builds until it physically collapses the trachea.
What do you do? Call for a CT scan?
Absolutely not. You have seconds, maybe minutes. You do not send them to radiology. You do not even wait to get back to the operating theater if they are crashing. This is a bedside emergency.
They do it right there.
You grab a scalpel, a stitch cutter, whatever is on the dressing trolley. You open the skin stitches. But that's not enough. You have to stick your finger in and release the strap muscles. You have to open the deep layers.
And the blood just sprays out.
It sprays out, the pressure is released, the trachea pops open, and the patient takes a huge gasp of air. You have just saved their life. Then you can take them back to theater to stop the bleeding in a controlled way.
Wow. That is intense. And it leads directly to our final check-in question 3.
Yes. Why do we avoid a watertight closure of the strap muscles when we sew the patient up at the end of the operation?
Why do we stitch it super tight?
The answer is to allow blood to escape. If you sew those muscles shut tightly, any bleeding becomes a high-pressure trap that will crush the windpipe. If you leave some gaps, the blood can leak out under the skin. You get a hematoma, which looks ugly.
But the patient can breathe. Ugly but alive. I like that philosophy.
Me too.
Baily and Love also mentions other complications, like hypocalcemia.
That's from damage to the parathyroids. The patient gets tingling in their fingers and around their mouth. It's called tetany. You have to give them calcium quickly.
That thyroid storm.
Very rare now because we prepare patients so well with carbimazole, but it's a life-threatening, massive release of hormones if you operate on a hot, unprepared patient.
We have covered a huge amount of ground today. From the base of the tongue all the way to the operating theater. Let's head to the outro and summarize.
Okay, if you only take 3 things away from this entire deep dive, make them these.
Number 1.
The RLN is the king. You must know its course.
Yeah.
Left under the aorta, right under the subclavian, and always watch out for that non-recurrent one on the right.
Number 2.
FNAC cannot diagnose follicular cancer. Yeah. See the capsule. A Thy3 result means you operate.
And number 3.
A post-op hematoma with stridor requires immediate opening of the wound at the bedside. Do not wait. Do not get a scan.
And let's leave our listeners with a final provocative thought. The source, Baily and Love, mentions the rising incidence of papillary microcarcinomas.
Yeah.
These tiny cancers we're finding because our imaging is so good now.
Yeah, we're finding more and more of them, yet the mortality from thyroid cancer stays exactly the same. We're finding cancers that were never going to kill the patient.
And the outline we had suggests pondering the Japanese approach mentioned in the text.
Active surveillance. In Japan, for many of these small papillary cancers, they often just watch them. They don't operate. And they've shown that usually nothing bad happens. So it raises the question, are we over-treating in the West?
A fascinating and important debate. Well, that is our deep dive. Go and crack open the 28th edition of Baily and Love, Chapter 55. Read the text with this audio map in your head.
It's been a pleasure.
See you on the next deep dive.